Hello, I hope I'll be audible now. I think so, Dilip. Just give me heads up. Is me audible? Am I audible? If I'm audible, just let me know. Hello. Yeah, great. Hello, Pradeep. Fine. So we have NEET PG Compact. I hope you are aware of it and just give it a shot. If you are in the top 200, you might grab some discounts. Fine. And we have few limited period offers, and there is an NSET free grant test coming up. So this will be the navigation flow in the app as well as in the website. You can attend it anywhere. Fine. Okay. So we will go to the question straight away, right? I just want you to read the question, take some time, read the question, and then give the right answer. Fine. Let's go and let's start. These are questions from you world or your different source of USMLE. Okay, what could be the answer? Probable answer. There are multiple learning points of this question, though there are only 3 or 4 lines here. There are multiple learning points here. The probable answer, any attempts? I think you guys should attempt it, right? It's a simple one. Fine, let's go ahead with the question. I'll read along with it and see. Yeah, Jay is correct, Dilip is correct. Yeah, great. So C will be the correct answer. Perfect. Fine. So we'll go through the question and see what else we can get from the question. A 3-year-old boy diagnosed with thalassemia major and received multiple transfusions maintains his blood hemoglobin level. So to maintain blood hemoglobin level in thalassemia major, at least you require weekly transfusions. So weekly transfusions having definitely for an entire year or more than that, because thal major can start appearing from 6 months of age, right? So definitely there is a chance of an iron overload. Fine. So my iron overload is a predominant problem here. And also the question says that the patient's liver and spleen is mildly enlarged. Which of the following therapies will prevent the congestive cardiac failure in this patient? See, first thing, I have to know whether this person is suffering from iron overload or not, right? So without knowing that, I will, and because congestive cardiac failure is possible in iron overload, because iron overload, the hemolysis, secondary hemolysis can cause you cardiomyopathy, which can cause you relative heart failure, right? So this patient is having an iron overload or not. So what do you think? Is the person suffering from iron overload? Do you have any history, anything suggestive of iron overload in this patient? Yes, no, probable, possible, anything? We do have few informations given which is suggestive of an iron overload. The question also says that he has a glucose intolerance demonstrated by the glucose tolerance test. A 3-year-old kid having glucose intolerance, see, that itself is unlikely for me, right? The person is glucose intolerant. I cannot explain glucose intolerance in a 3-year-old kid. So am I right in saying that if the person's pancreas is getting damaged, is there a possibility of glucose intolerance happening here? If there's a pancreatic damage, yes, possible, right? So now here, let's assume what will happen to secondary hemolysis, or the same pathogenesis is going to spill onto your hemochromatosis as well, right? So when you have an iron overload, so iron overload is going to attack many organ systems. The first one is going to be liver will be damaged. Liver damage is definitely the common one, because all the excess thing is going to go to the liver, will release a free radical and will destroy the liver. The second most important thing is pancreatic damage. Fine. So even in pancreas, what happens is, say I'm having an organ which is getting let's say 1 unit of blood supply, and having another organ which is getting 10 units of blood supply. Tell me, in these two organs, which will get more affected due to iron overload, the 1 unit blood supply or the 10 unit blood supply? Obviously the 10 unit blood supply, right? So the more delivery of the blood, more deposition of the iron, more is the damage, right? Logically. So when I take pancreas, I need the most active cell. See, the most active cell is the person who's going to get damaged more commonly, right? So exocrine was endocrine pancreas. Endocrine pancreas are the most active cells, especially amongst that beta cells. So what happens is in pancreas, you'll have a beta cell damage. Beta cell will be damaged. Once beta cell is damaged, yes, the person is having a glucose intolerance. That explains this kid is already suffering from an iron overload. A 3-year-old having a glucose intolerance, just make sure there's an iron overload. So definitely I would require some preventive measures to stop the damage. The same thing is going to happen to the heart. You will have in heart Iron can cause two types of cardiomyopathy. It can cause dilated cardiomyopathy as well as restrictive cardiomyopathy. Fine. Your UL talks about both. Definitely when I'm going to go to incidence, dilated is more common than restrictive, but hemolysis can cause both dilated as well as restrictive cardiomyopathy. Fine. One more important thing, generally this also will be there in question, a stunted growth. Okay. That is not here, but generally stunted growth is also possible in thalassemia. When a patient with thalassemia has a stunted growth, I have two probabilities. One, thalassemia per se can reduce the growth of the kid, right? Because not enough iron, not enough blood supply, the kid is going to have a stunted growth. One is due to thal per se. The other one is due to iron-induced pituitary damage. Again, the most active cell during a young age or an adolescent age is going to be growth hormone. So growth hormone will be destroyed. Because of that, I'm going to have a stunted growth, right? Pituitary damage due to the growth hormone being reduced, fine. So these are the different possibilities. There are a few more as well. We'll be discussing maybe sometimes down the road. These are the different possibilities of an iron overload, and the only way to stop an iron overload is I'm going to give an desferoxamine. You give desferoxamine, so that's going to, it's an iron chelator. It's an iron chelator. Definitely, it will reduce my iron overload, right? So we know a little bit about iron overload for sure. Okay. So as you guys said, C is the correct option here, right? We'll go to the next question. Again, read the question. Careful. I'll give you 1 minute, maybe, and then you can come to the answer. It's a simple one. Let's give you 1 minute. So 1 minute enough. So the answer, the probable answer. Great, right? It's a simple question. It has nothing to do with the question. The question is dealing with something totally different. See, this type of questions are very common in your world. This and this is not at all related. So it is like a complex thing. I have to read the question, diagnose the question, and similar finding elsewhere in the body, right? Since this is a very, very easy one, we are able to answer it easily, right? It's a classical case of a metaplasia. And here it's going to be in severe heartburn, we're going to talk about Barrett's esophagus, right? It's just Barrett's esophagus, right? As you guys said, it's a metaplastic reaction. So when I'm going to look at the options, bronchial epithelium cells in a cigarette smoker will definitely undergo metaplastic change. So that was the original option, right? Almost all of you answered option A. How many of you had time to read all the options? I hope you read all the options, right? Just make it sure you read all the options. That should be ingrained in your system, fine? So let's just take a detour and understand about this. In a bronchial epithelium cell, what type of metaplasia do we see? Barrett's, we know one type of metaplasia. In bronchial epithelium, I'll have a different type of metaplasia. What type of metaplasia do you expect in bronchial epithelium? You'll expect here squamous metaplasia, right? So here my pseudostratified columnar epithelium, which is the normal lining epithelium of the bronchial tree, will become squamous. That's a squamous metaplasia, fine? So the next thing, an epidermal cell in a patient with psoriasis. So tell me what is going to happen. Like if you're going to talk in terms of cellular adaptation, which cellular adaptation will fit here? Epidermal cells in patients with psoriasis. Okay, we'll look at the other options if possible. Can I say an epidermal cell in psoriasis will have an hyperplastic response? For sure, right? Will have an hyperplastic response. Though I don't read it as an example of an hyperplasia in the first chapter, you will have a very high turnover, so that will be a hyperplastic response here, fine? The next one. The melanocytes in a large and an irregular mode. Hyperkeratosis, more thing. Hyperkeratosis, Prithvi, you're right. It stems from hyperplasia only, right? So I'm just writing hyperplasia. Hyperkeratosis, parakeratosis, those are the effects of hyperplasia, fine? Option C. Melanocytes in a large irregular mode. What do you think would have happened? Can I fit into any of the cellular adaptation? Is it possible? Melanocytes in a large irregular mode. Actually, I cannot exactly write what will be the adaptation happening here because I have to understand what type of mole it is. If I'm going to take a melanoma, if the diagnosis is melanoma, then I'm going to say a neoplastic response, right? Since it is large and irregular, I suspect if it is a melanoma, the only response I'm going to see is a neoplastic response or a dysplasia. That will be the either of this which can fit in, fine. If it is a melanoma, again, as I said that I need the exact diagnosis. Once I have the exact diagnosis, I'll be able to say, okay, this is the problem happening here, right? Option D, myocardial cells in a patient with aortic stenosis. This can actually fit into an hyperplastic can fit into a cellular adaptation. What do you think it will fit into? A myocardial cell in an aortic stenosis. Yeah, you're right, Sanat. A, B, C, D, E, and all those things. In aortic stenosis, my heart is going to pump more. So perfect, you're going to have a cardiac hypertrophy, right? That's great. I'm going to have a cardiac hypertrophy. So what we generally read is in response to an hypertension. Here I don't have hypertension. I have an aortic stenosis. It's going to respond the same way. Yes, it's going to respond with the concentric hypertrophy. Perfect, right? That is also my hypertrophy, fine. Option E, skeletal muscle myocyte after prolonged immobility. So which of the cellular adaptation will fit here? This is also a classical example. This is prolonged immobility. I might rephrase it as disuse so that we can easily understand what's happening here. This is nothing but an disuse atrophy, right? Nothing but a disuse atrophy. Perfect. So the good thing, as I told this in the last class as well, the good thing about an USMLE question is each of the option will make you revise whatever you are studying, right? Whatever subject it is, not only pathology, everything in UWorld is so well organized that you'll be able to recollect everything, right? So spend time when you're solving UWorld, every option, look at every option, the explanation also will be perfect, fine? So just to ask you one more question, if I have to find a pigment in an atrophic tissue, what color will be the pigment and what will I name the pigment? There's a pigment which can happen in atrophic tissue. What color will be the pigment and what name will be the pigment? Okay. The pigment is going to be brown in color and I'm going to call it lipofuscin, right? The lipofuscin, the wear and tear pigment will be there in atrophy. That's why we use the term brown atrophy of heart, fine? Great. Okay. Well, the next question. Okay, read the question carefully and as usual, give the answer. Perfect. 1 minute. After 1 minute, we'll discuss the question. Okay, the possible answer. It's again a simple one, right? The questions when the general pathology in UWorld are a little bit simpler. I won't consider this cautious, right? Well, it's not cautious, like it's a classical case of a coagulated necrosis, right? A 65-year-old person came to the emergency department, acute right-sided flank pain. That is a history, suggests two of this. Nausea, vomiting can be a sympathetic response, fine. Medical condition is a prostate cancer and membranous nephropathy. Actually, this and my diagnosis may not have a direct link. On physical examination, the person has a moderate distress due to the pain and the person is diaphoretic. There's a right costovertebral tenderness, hematuria is there. CT scan shows a wedge-shaped defect in the perfusion in the kidney. There's nothing but a wedge infarct, right? Generally, we have a wedge infarct. Kidney, the end artery will be blocked. The blocking could be due to any thrombus or could be an embolus from the cancer, whatever it is, right? Something is happening and this is nothing but a wedge infarct. The perfusion defect is nothing but a wedge infarct. So wedge infarct of the kidney, it's a solid organ, right? Any solid organ undergoing infarct will have a coagulated necrosis. There's no problem in this. It's a straightforward question of a coagulated necrosis, right? So again, we'll look at the other options. Caseous necrosis, possible diagnosis. Caseous necrosis, possible diagnosis. Yeah, caseous will be your tuberculosis. That's the first thing. Since it is an USMLE question, so do little bit concentrate on histoplasmosis and coccidioidomycosis as well. So generally, when you are attempting a NEET PG or anything, I would unlikely to say it's predominantly tuberculosis only. The reason why I'm saying histoplasmosis and coccidioidomycosis is you must have read in microbiology these two diseases, histoplasma and coccidioidomycosis, will have classical association in the lung. So the classical association with the area. I can have a person coming from the desert I can have a history like that for blastomycosis, like that I have for coccidioidomycosis, I can have for histoplasmosis as well, right? So these are more important in an MLE question. If it's a tuberculosis, what they're going to talk about, you know how they will start the question with, right? Yeah, the wordings, the place are very, very important, right? If it's tuberculosis, the first thing will be a person coming from Middle East, right? Or an Asian person coming to us, and that's how it is, right? So you'll have very, very classical history. That history will lead to your diagnosis. The epidemiology is very important for USMLE. It's not unlike in NEET PG. This place is predisposed to this disease, so diagnosis becomes very easy, right? So there are many questions which is meant only for that. So please concentrate on that, fine? Fat necrosis. Just for a discussion sake, we divide fat necrosis into two things. One is my enzymatic fat necrosis. This is the routine fat necrosis we all must have read in your pancreatitis, right? I'll ask a question and the peripancreatic tissue. You're going to answer. So when I have pancreatitis as the history, so what do you think will happen in pancreatitis? The pancreas. Fat necrosis or liquefaction necrosis? In these two options, which you think will have fat necrosis, pancreas or the peripancreatic tissue? The answer should be a peripancreatic tissue, right? Pancreas will never have a fat necrosis. Pancreas actually has a liquefaction necrosis, right? Pancreas actually has a liquefaction necrosis. Because of the liquefaction, all of them will come outside. That will be in the peripancreatic tissue. The peripancreatic tissue, yes, like the lips, saponification, everything happens in the peripancreatic tissue or the omentum, right? This will have the fat necrosis. The pancreas per se will have the liquefaction necrosis. Be clear for that, fine? And obviously, the one more type of fat necrosis, traumatic fat necrosis. I think you world has a question on traumatic fat necrosis. There's a player being hit in the breast via the ball, and that can cause a traumatic fat necrosis. I don't want you to remember that only after an injury I can have a traumatic fat necrosis. It need not be a trauma. It need not be an accident. As simple as injections. You must have read this in your pharmacology. Insulin injections, they will cause a problem. Long-term insulin injections, what is the side effect? Something happens to adipose tissue. What is that? Lipodystrophy. Lipodystrophy. The lipid gets destroyed in every trauma. It need not be always an injury related to anything, right? It can be anything. Fine. Antibiomo is different. This can be any thing. You can have a trauma. Trauma can be as simple as injections. The injections per se can cause a fat necrosis, right? It's very, very pronounced in an insulin because I give them repeatedly. Normal gluteal muscle injection, IM injection, once in a time I'll have it, then it'll automatically heal. Repeated injections can also cause a trauma. At the same time, any organ which is rich in fat, the breast, the abdomen, the thighs and the deltoid. These are the places where I can have a traumatic fat necrosis, fine? Next we'll come to fibrinoid necrosis. Fibrinoid necrosis, remember only one person. Vessels. Any vessel which is getting damaged due to any cause, can be due to your immunological damage like SLE, can be due to a vasculitis of chronic inflammation, acute inflammation, can be an infection, can be malignant hypertension. Whatever may be the cause, if it's vessel, it's going to be your fibrinoid necrosis, right? Yeah, any vasculitis per se, fine. So second, the last but one, liquefaction necrosis. We know brain infarct for sure. I'm not going to talk about brain infarct. I do have liquefaction necrosis in few other conditions, like we just discussed. Pancreatitis will have liquefaction necrosis. The other one where you'll have liquefaction necrosis is your abscess cavity. Remember this. This is especially important when it comes to lung, because why I am telling in lung is you might make a mistake. Generally, what we think is whenever I have a lung history, the first thing what comes to my mind is tuberculosis, and I'll write caseous necrosis. If lung has an abscess, even if it's secondary to TB, it will not have caseous necrosis, it will have liquefaction necrosis, right? So if it is abscess cavity anywhere in the body, let it be brain, let it be lung, let it be in the hand, whatever it is, it's going to have a liquefaction necrosis, right? Tissue calcifications and extra intracellular accumulation, you might see them later, fine? That's a little bit discussion about this question, fine? I'll go to the next question and just read the question as usual and give us the answer. This is a little bit of a stretch, so 1 minute, entire 1 minute, I want to give you the answer. Okay, most possible answer. 1 minute is up. It's okay if you write it wrongly. I'm not going to judge you at any point of time, but do comment. Yeah, I've just got 2 responses. I'm sure many of you guys are here who can answer it. Okay, what do you think is the diagnosis? We'll go with the diagnosis, then we'll try to arrive to the answer. A 3-year-old African American brought to the emergency department with his parents, 3-hour history of swelling and tenderness in the hands and feet. I'm sure you know the diagnosis by this time. And perfect, you have a classical diagnosis of sickle cell anemia. Great. The boy attends the care, unsure of this any context. There's a family history, and the older brother died to pneumococcal sepsis at the age of 6. So I'm having a classical disease of sickle cell anemia, right? So which of the following is the most likely abnormality seen in the patients? Do you think sickle cell anemia has any relation with my left ventricular systolic function? We have spent quite a bit of time in understanding and reading about sickle cell anemia. Sickle cell anemia has nothing to do with your heart function, right? There's nothing to do with the heart function, right? Next, albumin. Albumin, in other words, liver. So liver damage in sickle cell anemia is also unlikely. Spleen can undergo damage. That's the reason maybe you'll have capsulated organism, pneumococcal sepsis in the brother, possible. But liver damage in sickle cell anemia is unlikely, right? So liver is also not going to get damaged most of the time, fine? Again, I will not have a secondary hemolysis here because sickle cell anemia does not require so frequent transfusion like my thalassemia, right? Okay, yeah. Third one, my serum C4 complement fraction. Do you think there is any problem in the complement interaction in sickle cell anemia? Definitely no complement interaction in sickle cell anemia. So that's also ruled out. It's not a complementopathy. Maybe in PNH I might have this problem, but here it is nothing to do with complement function, right? Fourth problem, serum haptoglobin. So serum haptoglobin, will it get altered in case of hemolysis? The answer is yes. In which type of hemolysis will it get altered? Intravascular or extravascular? It will get altered or it will be reduced in case of an intravascular hemolysis, right? So in case of an intravascular hemolysis, my serum haptoglobin will be reduced. Perfect. So now comes my question. In sickle cell anemia, do I have intravascular hemolysis? Because it is later than hemolytic anemia, so I have to prove that sickle cell anemia it will be altered, right? If it's an extravascular hemolysis, it will not be altered. So what is the type of hemolysis in sickle cell anemia? Intra or extra? So sickle cell anemia, I'm going to have a normal hemo RBC like this. So it becomes sickle like this, few of them, right? Few of them will become irreversibly sickle like this, right? So what happens in sickle cell anemia is, this sickled RBC, when they get trapped in the spleen, they will be destroyed. That's one thing for sure. If I'm going to have a damage, right? Good evening, Sarthak. If I'm going to have a damage to the RBCs from the hemoglobin, the unsoluble hemoglobin, that can have a very severe damage which can also cause an intravascular hemolysis. If the HPS concentration is very severe, it can directly cause an irreversible damage. When it's an irreversible damage, I do have a slight chance of intravascular hemolysis also. Sickle can have both intravascular as well as extravascular hemolysis, both of them. So if I have both of them, I am right in saying that I will have slight alteration in the haptoglobin levels, yes or no? I'm going to have both of them, so definitely my haptoglobin levels will be altered, so that will be my answer. Other two options, yeah, nothing to do with the systemic venous pressure or your urine cortisol level, right? Both can be seen in sickle cell anemia, fine. So since we came to intra and extravascular hemolysis, do you know any other hemolytic anemias which can cause both intra as well as extravascular hemolysis? Like G6PD, perfect, Prithvi. So G6PD can also cause both intra and extravascular, but the problem in G6PD was a bit different, right? I'll tell that as well. So when you have a G6PD deficiency, I'm sure you know that the problem in G6PD is not due to the enzyme, it's due to the reactive oxygen species. So I'm having a perfect RBC here. I'm right in saying that the amount of reactive oxygen species, the load can be heightened or minimal, right? So if I'm having a minimal reactive oxygen species, or if I'm having an increased concentration of reactive oxygen species, a minimal reactive oxygen species will cause a partial damage. When it causes partial damage, they're going to become spherocytes. When it's too much of reactive oxygen species, it can easily rupture the membrane and I'll have intravascular hemolysis. So where will this spirochete go again? It will go to the spleen and it will be destroyed. It will have extravascular hemolysis, right? So I can have both intra as well as extravascular hemolysis in G6PD deficiency as well. Do you know any other disease where I can have both intra and extravascular? Anything which comes to your mind? Autoimmune hemolytic anemia is also one of the disease where I can have both intravascular hemolysis and extravascular hemolysis, right? Both complement mediated hemolysis, intravascular, and also my phagocytosis due to the antibody binding, extravascular. Fine. Okay. So this might have been a difficult question. It's not difficult. You have to arrive to it. See, if I don't have the answer straight away, you know the diagnosis. I'm sure all of you must have come to the diagnosis in this question, sickle cell anemia. Just look at one by one option, whether it's fitting or not. The only one which will maybe at least remotely fitting is serum haptoglobin. Mark it as an answer. That's all. Fine. Okay. Next question. Read the question carefully and come to the answer. It's a very simple one. Take time. Need not be in a hurry. Read all the options and then write the answer. Okay, 1 minute up. Answer. Okay, we'll simplify the question. I'm sure you'll be able to answer that later. I have a history of something. A pap smear was done. A squamous intraepithelial lesion that tests positive for human papillomavirus. A cervical biopsy shows an low-grade dysplasia. Okay, that's what is shown in the cervical biopsy. The question what is asking is, what is the difference between low-grade dysplasia versus a cervical cancer, which is malignancy, right? So the question is this: low-grade dysplasia versus malignancy. So when I use the term dysplasia, am I right in saying that it will have pleomorphism, high NC ratio, loss of polarity, mitosis, right? You'll have. So any dysplasia will have these findings, right? Undoubtedly. So I can strike them away. Mitosis will be there in both in dysplasia. See, cancer undoubtedly will have all these findings, right? Disordered maturation, yes, definitely will be there in dysplasia. Loss of polarity, again, yes, definitely will be there in dysplasia. Nuclear abnormalities will be there in dysplasia as well as cancer. Pleomorphism will be there in dysplasia as well as cancer. So first, all 5 are common for both dysplasia as well as a cancer. Actually, in real life, what I'm going to look for cancer is my invasion of basement membrane. If my basement membrane is invaded, cancer, otherwise dysplasia. Okay, few of you answered D. Nuclear abnormalities is definitely a problem in dysplasia also. That's how I differentiate a normal from your dysplastic epithelium, right? Lib, you answered C. Why I'm not taking C is, I'll just go to this, right? Let's assume this is my epithelium, my squamous epithelium, all the 5 layers here, and this is where I have the acellular layer. Fine. When I have a low-grade dysplasia in cervix, I am right in saying that the 1/3 or 2/3 is affected. 1/3 being affected is this. So till this 1/3, I'll have nuclear pleomorphism, everything. That itself is loss of polarity. Polarity means everything should be perfect. So slight alterations in polarity is also called as a loss of polarity, right? If it's throughout, definitely loss of polarity, right? So loss of polarity is also seen in both. The only thing which is differentiating both is reversibility of the changes, right? This I am sure you know that as well. You must have read in your gynecology postings and your gynecology. If I have a low-grade dysplasia, do we do an hysterectomy? We don't do an hysterectomy, right? Maximum I'll do a conization or maybe loop and leap. You must have read about that. I am not going to go for a very radical surgery because it is reversible. Sometimes I just wait and watch, right? I wait and watch. So definitely a low-grade dysplasia is reversible. When it becomes high-grade, it is not reversible. I have to go ahead with the radical surgery. Same thing for my Barrett's esophagus as well. For a Barrett's esophagus, treatment is proton pump inhibitor. Low-grade dysplasia, still proton pump inhibitor. High-grade dysplasia, okay, I have to do something aggressive because high-grade dysplasia definitely becomes later. No, Sarthak, not every dysplasia is irreversible. Low grade dysplasias are reversible. That's why you need a pathologist to say it's a low grade or high grade. The reason why I have low grade is if it's in Barrett's esophagus, still proton pump inhibitor is a thing. If I want to go into the surgery, I'll look for the extent of involvement. Tiny 2 cm low grade dysplasia, still I can wait and watch. High grade dysplasia, I cannot wait and watch. Fine. Dysplasia, low grades are reversible, higher grades are irreversible. Fine. No, even low grade dysplasias are reversible. Okay. Okay, this is a big question. I just want you to read this question. Once you read this question, say yes, done. I'll go to the options. Fine. Because I cannot put an entire question in a single page, so I add two things. Fine. 1 minute. It's a very good question. Once you're finished reading the question, let me know. Make a presumptive diagnosis, then I'll look at the options. Okay, done. Fine, I'll look at the options. Now tell me based on this, what is the correct answer? I have 5 options here. As you guys said, the diagnosis here is nephrotic syndrome. Just tell me which of this will be perfect in a nephrotic syndrome. Now it's become simple, right? I said it's a very good question. If you know everything about nephrotic syndrome, you can easily crack this. Okay, see. I want every one of you to comment. It's fine if you are wrong. It's okay to do mistakes here so that you will not forget again. Okay, C. Okay, to all of them who answered C, tell me why C. Because you are partly correct in saying C, but part of them is not correct. Tell me why C. It's not because of hypocomplementemia it will cause C. Thromboembolism, there is an increased episode of thrombosis in nephrotic syndrome. Why? Because I'm sure you must have read that nephrotic syndrome, there is a loss of antithrombin, right? You'll have an antithrombin loss. When you have an antithrombin loss, okay, antithrombin will be lost, perfect. So I'll have risk of thrombosis, understood. So do you think I'm having a patient with nephrotic syndrome? For every patient with nephrotic syndrome, this is possible, right? Antithrombin loss is possible. So do you think for every patient with nephrotic syndrome, you give prophylaxis, or you will give prophylaxis for a person who has a history of thrombosis? For a person who has a history of thrombosis, right? This is partly correct. Thromboembolism risk is there, but I don't require prophylaxis for every patient with nephrotic syndrome. You must have seen cases with nephrotic syndrome. You don't give prophylaxis for every patient. If the patient has an episode of thrombosis, I'll then give it, right? So that's partly correct, so I'm going to rule out the option, right? Urinary loss, no. Urinary loss of calcium is not a problem. It's protein loss, so it's not a calcium loss. Spontaneous bacterial peritonitis, it has nothing to do with nephrotic syndrome. We'll rule that out as well. Acute renal failure due to intrinsic renal failure. Again, nephrotic syndrome, unlikely to cause this, fine? Yeah, right. So now look at the option E. By exclusion, the only thing which fits in here is option E, right? So tell me, how can you justify option E? Spontaneous bacterial peritonitis is unlikely to have hemolysis. How can you justify option E? Answer, I'll tell you answer is option E. I just want you to justify. How do you justify option E? Option E is microcytic hypochromic anemia, poorly responding to oral therapy. Anemia of chronic disease, erythropoietin. Okay, see. Okay, I'll come to both of whatever you have said. Anemia of chronic disease, it's predominantly normocytic or microcytic, as well as erythropoietin defect, normocytic or microcytic. Both of them are normocytic, right? I can say this, anemia of chronic disease or due to anemia of renal failure, that's due to erythropoietin. Both of them will be normocytic RBCs, right? Both of them will be normocytic RBCs. Still I have microcytic. It doesn't fit into, right? So I have a classical case of microcytic anemia which is poorly responding to iron therapy. The reason why this will be the answer is, in nephrotic syndrome, I am right in saying that there is a protein loss, right? If I have 3.5 grams of protein going outside of the body, is there a slight possibility transferrin can also be lost? Perfect, right? So transferrin can also be lost. Okay. When transferrin is lost from the blood, do you think the iron whichever the body has will reach the erythroid? It will not reach the erythroid, right? Once transferrin is lost, the iron whatever I had will fails to reach the erythroid. Once it fails to reach erythroid, what's going to happen is I can't do anything, right? Because of this, I'll have an IDA. The problem with this anti anemia is you will give iron therapy. Let's say I'm giving oral iron. Will the oral iron work? It will not work again. The problem, same thing, because oral iron also requires transferrin to carry it there. It will not work again. So the only way to treat this anti anemia is treat the nephrotic syndrome. Stop the proteinuria. Stop the protein loss, then automatically it will come back. Fine. Okay, this is the correct answer. It's due to transferrin loss, like Prithvi said. Okay, that's a classical case of nephrotic syndrome. You have, how do you come to a nephrotic syndrome? One, I can come for the first line itself, right? What do you think is mostly the diagnosis? Minimal chain disease, 7-year-old, something like a minimal chain disease. There is no recent history of URI, no decreased urination, no hematuria. When I say no decreased urination, my acute renal failure goes away. Fine, everything goes away, right? And have an periorbital puffy edema, abdomen distension with fluid thread. So most likely edema is the primary function due to hypoalbuminemia, which is going to be your urinary protein 4+, definitely your nephrotic range, and this one as well. Fatty cast is almost diagnosed with nephrotic syndrome. Nephrotic syndrome is my diagnosis based on all these findings, and I can easily say that the reason why, which is the correct answer, is option E is the correct answer. Fine, great. Okay, hopefully we read one new thing today here. Transferrin also will be lost in nephrotic syndrome, which is going to cause it. Fine. Next question, read it carefully and come to the answer. Okay, 1 minute again. I'll answer your question, Prithvi. Okay, answer. Answer. You can exclude and answer it, right? It's a simple one. You have the classical history. What is the diagnosis? Tell me the diagnosis, we can come to the answer. You have a patient with psoriasis and you have joint problem. So obviously my diagnosis, you have the right hand swollen, nails both, everything is appearing pitted. So my diagnosis here, psoriatic arthritis, right? So my diagnosis here is something related to psoriasis or psoriatic arthritis. Perfect. E is the correct answer. You can easily rule out everything and write the answer. A local invasive infection into the joint space. So for which diagnosis, option A will be the correct answer. Local infection into the joint space. This would fit for an septic arthritis, right? Okay. For a septic arthritis, option A will be the correct fit, right? Septic arthritis is common in different age groups. You must know that. In orthopedics, you must have read about it. That will be the correct answer. Perfect. So a repetitive injury, a repetitive damage to the your cartilage or to the substance of the cartilage. What could be the correct answer? Repetitive damage, most likely this is due to osteoarthritis. Osteoarthritis, the classical reason is repetitive damage, right? The weight is one of the important cause. Slowly micro damage will happen to the cartilage. I'll lose the cartilage, then I'll have an cortical loss and I'm going to have an osteoarthritis. That will be the answer. Option C and option D are classical. Antibodies to FC fragment of IgG, rheumatoid arthritis, right? And deposition of the crystals to the joint space. This is, I'm writing gouty or pseudo gouty arthritis. Fine, because gout as well as pseudo gout, I'm going to have crystals that's going to deposit and I will destroy it. Charcot joints also can be, right? Repetitive damage can be there, but in a very, very long run. Charcot is like an end stage, right? Okay, coming back to your doubt, Prithvi, yes. The most common cause of minimal chain nephrotic syndrome in a kid is minimal chain disease. In an adult, yes, I'm going to think of an FSGS. In an elderly person, I think of a membranous glomerulonephritis. For the only reason, in elderly person, the risk of malignancies are more. Malignancy associated nephrotic syndrome is generally membranous type. That's the reason we go for elderly. Fine. Okay. So option E is how psoriatic arthritis is going to exert this problem. Because psoriasis is an autoimmune inflammatory disease. There will be lots of inflammation in psoriasis throughout the body, and that inflammation will undoubtedly release TNF. It's an acute phase reactant, right? Interleukin 1, interleukin 6 and TNF. TNF will activate my rankle. Once rankle is activated, what's going to happen? Which cells will be activated in response to rankle? I'm sure you know that from your physiology of bone resorption and everything. Once rank ligand is activated, my osteoclast is going to have an upper hand that will slowly start eroding everything. When it erodes my bone, obviously it's going to end up in arthritis, right? So it's going to erode slowly and it will end up in arthritis. It will have damage to joint space and I'm going to have arthritis. Perfect, fine. So we read about all the 5 options and whatever disease probably it might cause, fine. Okay, next question. You can read the question carefully and give the answer 1 minute. Maybe less than a minute for this. It's a simple one. Good. And the I think the radiologist must have taught you, right? Radiological image of psoriatic arthritis are important as well for every exam. Okay. Fine. Okay, great. Tuberculosis, great. A 45-year-old presents with cough for 1.5 months. If you are sitting in India, cough for 1.5 months, my first possibility is tuberculosis, right? I don't even want to look at the second lines, but still. Night sweats, fever, loss of weight for 2 months, and there is a 6-month trip to Peru. I said, right, whenever you have any problem with Middle Eastern countries, low socioeconomic countries, I am going to talk about infection. That's one clue for USMLE. Wherever you have, this is the finding, fine. And you have your heart rate, and all those things are helpful for me a little bit, and there is temperature. The thing extra finding for me is opacity in the right apex. Fine. I didn't understand your question. Yeah, it's B only. Yes. So we have everything pointing towards my tuberculosis, and opacity in the right apex could be the pneumonia, tuberculosis induced fibrosis, whatever it is, which will cause opacity. And my answer is going to be tuberculosis. Echinococcus is not going to cause this classical finding. It will not. Pulmonary thromboembolism, cough for 1.5 months is not the classical presentation of pulmonary thromboembolism. Heart failure unlikely to present like this. 1.5 months without any breathlessness or anything. Respiratory rate is 17. Again, not a problem, right? Okay, I'll come to your doubts. Lung cancer. Fine. See, why I'm going to have lung cancer? Most likely not the answer here is lung cancer will not have fever. That's the reason I'm not considering lung cancer. I have a fever of 100.4, which is definitely the person is febrile, right? Patient is febrile and there's diminished heart sounds at the base. A lung cancer causing disturbance in the air sounds is unlikely again. Cough, possible in lung cancer. Night sweats, not possible in lung cancer. Night fevers, not possible in lung cancer. Weight loss, yes, possible in lung cancer. So everything doesn't fit into lung cancer, so I'm not going with the diagnosis. Fine. Tell me, what do you think is the commonest presentation of pulmonary thromboembolism? Since we have that in option, we are discussing that. Pulmonary thromboembolism. The commonest presenting feature of a pulmonary thromboembolism, or the sign, or whatever you know. Pulmonary thromboembolism, the commonest presenting feature is palpitations. or just tachycardia as a sign. You won't have anything apart from that, just a tachycardia. A DVT, I think you must have meant DVT. DVT must have been a predisposing finding. Fine. Just tachycardia and your palpitation. Most of the time, this will be the only finding. You have to suspect pulmonary thromboembolism. Like Prithvi said, that if there's a history of DVT or a prolonged rest surgery which can predispose to DVT, that should be there, right? Tachycardia in a bedridden person or in a recently operated prolonged rest, please suspect pulmonary thromboembolism and take an ECG so that you can have an early diagnosis and early management. Fine. Okay. Maybe for your step 2, ECGs might be required. One of the commonest ECG finding in pulmonary thromboembolism, yeah, like Prithvi said, that you should be able to pick it up in a real ECG as well, also in the MCQs. Fine. Okay. It's a simple one. We'll finish it in a few minutes. Okay, 30 seconds here. Hope that should be enough for this question. Okay, Lakshmi Kanta, hematuria. I'm not able to understand why you told hematuria. Okay, why are you guys ignoring troponin? May I have an understanding of why you guys are ignoring troponin? I just want to know why you guys don't like troponin. The question is asking, troponin will fall after a very long time, right? Troponins will fall after a very long time. That's one of the disadvantage for them. I cannot use it in a reinfarct. The classical case of an MI, I don't have any doubt in that. I am having a ECG is not there, but still your classical everything finding is just about MI, right? So they have a more specific and will remain elevated. Please read all the 5 options, right? Read all the 5 options and read the question carefully. Don't miss questions like this. Fine. Okay. It has to be troponin. CKMB, the only slightest advantage of CKMB is when I have a reinfarct very soon, like after 2 or 3 days I have a reinfarct, CKMB can help, right? Because it dips and it rises again. But still then, even for a reinfarct, the current practice, I'm not the right person to talk about the current practice, but ask your medicine faculty who is going to teach you, they'll still prefer troponin, because serial evaluation of troponin will still show a change, a slight change, that will be better, right? So answer is troponin I. It's more specific and it will be elevated even after a week of the event. Fine. Okay. I thought it's a simple question. You guys answered all the difficult ones. Simple ones, please don't make a mistake. Fine. Okay. Read this question carefully and then write the answer and tell the answer. Dilip will be correct regarding that, Prithvi. I hope it is clear as well. Okay, the most likely answer. I don't want you to jump to a conclusion. Read it carefully. Everything here helps in arriving to the correct diagnosis. Okay, others apart from Anuj. Anuj is the person to start it. C-A-D. Okay, I have lots of answers here, right? Okay, fine. I have one history here. I'll first go with one key point. A painless swelling, so which I can rule out. A painless swelling and a soft fluctuant swelling, right? And a non-fluctuant is somewhere soft swelling, not a hard swelling. If it's a painless swelling, I can definitely rule out dequavine thyroiditis, which is a painful thyroiditis. Renals also, little bit of pain. It will not be soft. I'm going to rule it out as well. Second thing what I'm going to use is a 3-week history. Do you think Graves presents with a 3-week history? Will Graves present with a 3-week history? 3-week and there is swelling in the thyroid. Graves doesn't present like that, right? This is very an acute onset, right? It's unlikely to be Graves. The only reason I'm removing Graves is the history. A very short history. In the short history, I'm having a swelling and I'm having a painless swelling. So can I say that this history is an acute nature? Whatever disease I'm talking, it's of an acute nature? Yes. I am not calling it an acute thyroiditis for the only reason every acute inflammation should have pain, right? So I'm going to call it an subacute thyroiditis. Subacute thyroiditis, is it painful or painless? It is painless, obviously, right? Subacute thyroiditis is painless. Subacute versus Hashimoto's. Silent thyroiditis is subacute thyroiditis, right? Now I have two options to differentiate. Now tell me, you will read through the question. 40-year-old person presents a 3-week history of painless swelling, which is dated 3 weeks ago. That's all. The swelling is associated with sweaty palms and everything. Irritability, everything is there. Weight loss is there. Vision problem is there. Body swelling is there. Fine. The patient's medical history is negative or similar thyroid disorder. Everything is negative. Vital signs is normal. Okay. That is also something unlike to it. Fine. And then I have a non-pulsating, non-functional mass and the patient has this. Can I diagnose Hashimoto's without serology? Okay, subacute was silent. The other name is silent. That's all. Advaita pathology counseling, I'm not sure. The results have not come. After results, it might happen. It's just all symptoms are suggestive of hyperthyroidism. That's all. Fine. So without serology, I cannot diagnose Hashimoto's thyroiditis, right? So I'm going to rule out Hashimoto as well. If I don't have serology, Hashimoto is not possible. Sweaty palms again, Hashimoto is not possible. Unlikely, right? Okay. So the only thing here it's a subacute thyroiditis. Like Priti said, the other name is silent thyroiditis. Whenever you have a painless, a very short history thyroiditis, go for this. And one more clue you can have is pregnancy related. Subacute thyroiditis is very common in pregnant women. A pregnant woman, a very short history, painless thyroiditis, painless enlargement of thyroid, subacute thyroiditis. The microscopy of subacute thyroiditis will have lymphocytes, will have Hurthle cells. Which other disease will have the same finding? Lymphocytes, Hurthle cells. Hashimoto's, right? So subacute thyroiditis can be reversible, can come back to normal, or it can stay like that and become Hashimoto's. The only difference between this and Hashimoto's, plus you have your serological evidence of autoantibodies, then I'm going to call it an Hashimoto's thyroiditis. You cannot diagnose something or label something as Hashimoto's like that. Fine. Okay. Yes, Advaita, we'll see soon together. Maybe in the first week of October, we'll have something on Unacademy as well. Fine. Okay. Perfect. Great. Next question. Read the question carefully and then write the answer. Okay, answer. Just a second. Where did it go? Sorry. The answer here? E. Great. Sorry, my screen disappeared. Fine. Okay, I have two things, D, IgM and E. Okay, what is the diagnosis here? My preliminary diagnosis here is multiple myeloma, right? That's my preliminary diagnosis. Here what I'm having is myeloma cast nephropathy. So I'm having a myeloma cast nephropathy here. Myeloma, or in simple words, myeloma induced renal damage. So tell me, of these options, which will cause myeloma induced renal damage? Heavy chain or light chain? Which we already know. There's only one thing which is going to cause myeloma induced renal damage, which is light chain, right? In urine, definitely light chain, right? So light chain is going to cause myeloma induced renal damage more than the heavy chain. So why it's going to be a problem light chain is, what happens is multiple myeloma, the light chains which are very smaller, which can get filtered by the kidney, and they're going to bind with TAM-Horsfall proteins. You must have read about TAM-Horsfall proteins, right? So this TAM-Horsfall proteins, once they bind, ideally where do I see TAM-Horsfall proteins is in the renal tubules. I'll see TAM-Horsfall proteins in renal tubules. It's normal or abnormal? TAM-Horsfall is very, very normal, right? So it'll either be absorbed or it'll go back a little bit as a cast outside the body. That's the fate of TAM-Horsfall proteins. But what happens if these both bind together is, they cannot get excreted nor they can get absorbed. So they're going to stay back behind. So this stays back behind, this complex will cause tubule damage. When tubules are damaged, definitely it's going to result in renal failure, right? So TAM-Horsfall protein binding with light chain is the cause of renal failure. So when this renal failure happens, few of these products comes out in the urine. That also you must have read in your first year. We were using it to diagnose this. What was that? No, uromodulin is a normal component present everywhere. I'm not understanding your query, Prithvi. This protein will be excreted in urine. We used to name them and we used to diagnose them as your Benz-Jones proteins, right? Fine. That's nothing but your combination of your light chain and your TAM-Horsfall protein. Yeah, Benz-Jones proteins. So here it's a myeloma cast nephropathy or myeloma induced renal damage that's due to your light chain and not due to your heavy chains. Fine. So the only option is lambda. And lambda light chains are more damaging than your kappa light chains. If both of them are given, still I will prefer a lambda light chain. Fine. Okay. The next question. Okay. Answer is I'll say. Which one can't be LCS, Sarthak? Perfect. Yes, Prithvi. TAM-Horsfall protein is nothing but uromodulin. Fine. Uromodulin gets secreted from the gene and it gets accumulated, which is a TAM-Horsfall protein. Okay. The previous thing was not LCH. It was a classical case of multiple myeloma. For 64-year-old history, I won't think of an LCH first of all. Fine. Age of LCH is predominantly children. 64-year-old primary presentation, I am not going to think of LCH. Fine. Okay. Fine. Let's come to this question. You have a classical case of CLL. The question is not about CLL. The question is asking about the test. I have a patient, I am going to suspect trisomy 12. So trisomy 12, which of the following investigations will help me in the diagnosis of trisomy 12? That's all. It's a trisomy. It's a chromosomal abnormalities. Any chromosomal abnormality, I need only your cytogenetics, either my karyotyping or FISH. Only these two can pick up the trisomy 12, and the only option here present is FISH. Enzyme linked immunosorbent assay, ELISA, will not be helpful to pick any of these things. Flow cytometry, again, it can tell me what is positive, what is negative, but it will not tell me about the chromosomal structure. Northern blotting is for what? And western blotting is for what? We have west, north, south, and all these blotting, right? You must know the blotting techniques better, which I read that in biochemistry. And you have specific utilities of the blotting. Though it is not used in recent times, you might have a question on medical genetics which can come on blotting techniques, fine? Especially in M&A exams, okay? Great. Here the answer is going to be FISH. Okay. Next one. This is also UOL question. This was maybe a new topic if you have not gone through UOL before. Read it and tell the answer. Okay, answer. Fine, perfect. I hope you must have read your word then, right? You must have been very thorough with your word. See, this is how methotrexate is going to act, right? Yeah. So what happens to methotrexate is, so methotrexate is going to enter whatever cell is going to attack. Once it enters the cell, so methotrexate will be converted to 1%, which is my polyglutamation. Methotrexate will undergo polyglutamation once it enters the cell. Methotrexate is a dihydrofolate reductase inhibitor. That's how it's going to attack the cells, right? It'll undergo polyglutamation. So there's a chemical change. The reason why it's going to undergo polyglutamation is this: once it undergoes polyglutamation, it can't exit the cell. Yeah, it's primarily biochemistry. It was there in pathophysiology, so I took it and that's fine. It cannot exit the cell. So what happens is, inside the cell, I'll have two components which can be stored. One is folic acid, because it's not getting used, because methotrexate blocks its conversion to other active components. The other one is my methotrexate polyglutamate. Fine. My methotrexate polyglutamate will keep storing inside the cell. So the question is based on methotrexate. What stores there is your dihydrofolate polyglutamate. The polyglutamate form, it's a dihydrofolate reductase inhibitor, right? That keeps on accumulating. What is the purpose of folinic acid? What is the purpose of folinic acid? Folinic acid is given to patients to circumvent the methotrexate induced folic acid deficiency, right? Because folinic acid will not be attacked by methotrexate, so that can be automatically consumed. It's like a drug which I'm going to give to every patient who is on methotrexate, right? Tetrahydrofolate, these levels will be elevated or lowered, again with methotrexate. I'm giving methotrexate to the patient. What will happen to the levels of tetrahydrofolate? Will be more or less? I'm sure you know the answer. Will become less, right? The active component of my folic acid, my tetrahydrofolate, that cannot form, so the levels of tetrahydrofolate is going to be less, fine? Okay, the last question for today, read the question and write the answer. I'll finish it in some time. Okay, probable diagnosis or the answer. I just have a very minimal history here given. B. Anyone else? It's a lymphoma case, but I don't have any finding, no microscopy, no immunohistochemistry. Okay, B, D, okay. You guys have to attempt, it's fine. If you answer it wrongly, I'm not going to do anything, right? Okay, we'll read through the question, we'll see what will be possible. A 42-year-old person, a healthy woman, comes to the office due to sore throat, okay, and there's no cough, nothing is there. Patient shows an X-ray in the tonsillar fossa, and there was a non-tender cervical lymph node that measures 3.5 centimeter diameter. 3.5 cervical lymph node is definitely significant, fine. Sure, Progesh, just a minute. It's definitely significant. Antibiotics were started. The patient said that it was resolved, and the next year, again the patient remains asymptomatic, and the size of node fluctuates, but has not disappeared completely. So I am not sure. Are you sure that this 3.5 centimeter lymph node is due to sore throat, or that would have been present in the patients before the sore throat as well? Should have been before the sore throat as well. For simple reason, it's non-tender. If it is due to sore throat, it will be a tender lymphadenopathy. Infection associated lymphadenopathy will be tender. When you have a non-tender lymphadenopathy, this itself is a problematic statement, right? 3.5 centimeter non-tender cervical lymph node, and that's still next year also, it's almost the same size. So I have a very long history. I have a long history of a lymph node enlargement. So if I have a very long history of lymph node enlargement, what I'm looking here is, I'm going to look at let's say low grade lymphoma. Yes, I'm going to look at a low-grade lymphoma. Why I'm going to look at a low-grade lymphoma is the patient is still asymptomatic. So do you think ALL will remain quiet for 1 or 2 years? It won't. It will cause cytopenias. It will cause fatigue. It's an aggressive neoplasm. So it's unlikely. That too, ALL in a 42-year-old will definitely aggressive neoplasm, right? Be definitely aggressive, not a problem. Burkitt's, it will definitely be not possible. Burkitt's, if I leave it untreated in a year, it will go to bone marrow, it will destroy almost everything. DLBCL, they'll kill the patient in 1 year. If it's untreated in 1 year, they won't fluctuate. They will spread all over and will kill the patient. Follicular lymphoma definitely fits to the profile. I am not saying it's follicular lymphoma. I have to take a biopsy to prove it is. But most likely, if it is a lymphoma, if it is an NHL, follicular lymphoma will be the best thing to fit into it, right? Hairy cell leukemia. Do you think it will present with lymphadenopathy? Hairy cell leukemia doesn't present with lymphadenopathy, right? They don't have a lymph node enlargement. It's the spleen and all those things. They will not have lymphadenopathy in hairy cell leukemia. Mycosis fungoides. Again, it's a skin lesion. Right? It's not. It can't happen in lymph node. It's not that it will not happen, but it's a skin lesion without an asymptomatic person with no possible skin lesions in the history. I am not going to think of a mycosis fungoides. The only thing which fits into my clinical profile is this, right? So the most probable answer here is your follicular lymphoma. Maybe we'll take a biopsy, and if it is a follicular lymphoma, you know what to look for. If it is a follicular lymphoma, tell me one IHC. I just want one. I don't want the entire list. One IHC you're going to do. If it is positive, it is follicular lymphoma. What IHC? Don't say every IHC. Want just one IHC. Perfect. I'm going to think on BCL2. If BCL2 is positive, it is follicular lymphoma. I do need other things to support my diagnosis, but yes, BCL2 is one thing which I'm going to rely on because the translocation is involving BCL2 and there will be an overactivation of BCL2. That will give my answer, right? Okay, perfect. So that's all for today's progress. Asked about atelectasis. See, atelectasis is nothing but collapse of the lung. I have different types of atelectasis, right? So atelectasis is if it's due to lung collapse. If others want to leave, you can leave. I'm just going to discuss about atelectasis. It has nothing to do with MLE. Since he asked, we'll discuss about it, fine. If you want to stay, you guys are going to help me with atelectasis, right? So when I say atelectasis, it's lung collapse. So there are different types of atelectasis. I can have an resorption atelectasis, compression and contraction atelectasis, fine. So resorption is one part. You can have a compression atelectasis. That's the other type of atelectasis. And I can have a contraction type atelectasis, fine. So when will I call it resorption type atelectasis? I'm going to have a normal bronchus. When the bronchus is blocked by a foreign body or a mucus plug, like in cystic fibrosis, it can get blocked, right? So that's getting resolved. This was my bronchial tree, fine. Okay, we have a bronchial tree and this goes like this, goes like this, goes like this. I have a foreign body getting stuck here. So this entire segment will be shrunken. That's going to be a resorption atelectasis, right? This is due to a foreign body. If it's due to mucus plug, I would expect like a cystic fibrosis like a lesion because there the mucus plug is going to be extremely thicker, fine. When I say compression atelectasis, as the name says, there's something compressing. I'm having a proper lung here, right? The bronchial tree, everything is normal. If I have pleural effusion accumulating here, am I right in saying that will compress it? Yes. A pleural effusion or a tumor in the pleura, it can compress it, right? So compression can be a pleural effusion or it can even be a pneumothorax. It need not be a pleural only or a hemothorax. Something in the pleural space is compressing the lung. It causes the lung to shrink. That's going to be my atelectasis. The third one is contraction atelectasis. Contraction, which means I'm having fibrosis. The lung parenchyma undergoes fibrosis. Because of that fibrosis, the lung will automatically shrink. The shrinking lung is going to be atelectasis. Fine. Those are three different types of atelectasis. I hope you know. That's all in brief about that progression. Okay. Fine. Okay. So we had two things. Okay. Great. Fine. All of them are from you only. We'll keep discussing few questions. Maybe can we have like 3 sessions a month for USMLE? If you guys are interested, it will be good for me as well. Let me know if you guys are interested. And I love USMLE questions because they are very logical and will help us to think more better. Okay. If you guys are in, we'll have a couple of sessions for it. Okay, sure. See, bronchiectasis, yes, bronchiectasis has many sequelae. Bronchiectasis per se, I'm not sure why you are asking it. If you have any history or something in your mind, please share me that question. I need to read through the entire thing to say whether that can result in atelectasis or not. Fine. Sandeep, textbooks. USMLE or NEET or next, everything is based on textbooks. Read the textbooks carefully. If I may know which year you are in, Sandeep, that will help me to give you better clarity. I'll keep you posted, Dilip. I'm not planned anything for this week, coming week. We'll definitely keep you posted. See, if you are in your second year or in your first year, fine, I would ask you to go back to your textbooks and read your textbooks carefully. If you come to your final years, USMLE is a little bit of an comparatively in second year, fine, great. I then say read Robbins, read Tripathi, read your standard textbooks. Maybe if you want in addition, solve U World. Read the textbooks, understand the topic. If you finish RBC, WBC platelets, take the U World hematology and start solving it. Because application is also key. If you apply that, whatever you have read, you will definitely make mistakes. From that, definitely you can improve for sure. Not only USMLE, Prithvi, like, see, you guys have to understand the base of every competitive exam. Any competitive exam is there on the earth, it's going to make sure, or it's going to select that you are a good doctor, that's all. The basis of every competitive exam is to make sure you're a good doctor or not by eliminating that. So if I'm going to have, if I have to test a good doctor's performance, I'm going to ask the common diseases. Maybe I'll twist it, that's it. So if I'm going to sit in a clinic, if I'm going to have anemia patient, predominant of them is going to be iron deficiency. So definitely there'll be a question on iron deficiency anemia. So that's how MCQs come. The way they ask us, they might ask you the common investigation, the relevant investigation, the specific something, so that you have a little bit of more theoretical knowledge as well. Most of the time, almost every exam, topics will be the same. Definitely in any exam, 20% of them will be weird questions. Don't go with that. 80% is what I'm targeting on. If you clear the 80% of the questions in any exam, you're going to be in the top. You have no problem in that, fine. Whatever it is, it will be the same. Sandeep, go back to your books, read the books. If you want to integrate and read, first aid is a good source where you have your cardiology, nephrology like that, so that you can have anatomy, everything integrated. You can read that as well. And U World is extremely important for MLE. It will cover all the basic things which you need. The higher 5 things you'll definitely know and you'll definitely crack it. Fine. Okay. Any other doubts? Okay, if there are no other doubts, we'll call it a day and hopefully we'll see you soon in some other USMLE discussion. Fine. Thank you for your time. Bye bye. See you.